60 million. Take a second to really think about that number. That is how many people worldwide are living with psoriasis right now. For decades, this condition has been frequently and, quite frankly, incorrectly dismissed as just a cosmetic skin issue. You know, people think it's just a simple rash or some dry skin, but as we're about to see, the true nature of this disease is way more profound and way more complex than just what meets the eye.
Welcome to this explainer. Today, we are tackling a core theme that's beautifully captured by the idea of an iceberg. What we actually see on the surface of the skin, the flaking, the redness, the plaques, is literally just the visible tip of a massive, complex immunological iceberg hiding beneath the surface. So we're going to explore the hidden depths of this immune-mediated disease and uncover what's really going on inside the body.
Here is our quick roadmap for this explainer. First, we'll look at the global burden. Second, the different phases of the disease. Third, we'll dive into the immune short circuit. Fourth, we'll go way beyond the skin. And finally, targeted treatments and hope. Let's jump in.
Part 1. The global burden.
The global footprint of psoriasis is actually incredibly varied. Depending on where you are in the world, prevalence ranges from a tiny 0.09% in parts of Africa all the way up to over 11% in Northern Europe. But what's particularly fascinating, and honestly a bit surprising, is the timeline of how it strikes. Psoriasis typically follows what we call a bimodal onset. That just means it tends to hit the population in two distinct age waves. So there's an early peak between ages 18 and 29, and a second onset later in life, typically between 50 and 69 years old. And while the actual clinical features might differ a little bit, it affects both sexes relatively equally.
Moving right along to Part 2, Phases of the disease. Now, when we talk about chronic plaque psoriasis, which makes up, about 80 to 90% of cases, the appearance can be vastly different depending on a person's skin tone. On later skin, you typically get the classic textbook presentation, bright red plaques with silvery white scales. But in skin of color, these exact same plaques can appear purplish or violaceous, gray or hyperpigmented, and the scaling might actually be a lot less prominent. This is an absolutely crucial distinction because this difference in appearance very often leads to misinterpretation and highly frustrating diagnostic delays for people with darker skin tones. And psoriasis isn't just something you find on the elbows or knees. Anatomical location matters immensely. Palmoplantar involvement, meaning on the hands and feet, along with scalp psoriasis behind the ear, are incredibly common, particularly in Black patients. And this isn't just mildly uncomfortable. Palmoplantar psoriasis can cause deep, painful fissures that totally impair basic daily functions, like walking or just using your hands. Meanwhile, scalp psoriasis brings intense, agonizing itching and very visible flaking. Then there's inverse psoriasis, which is another incredibly misunderstood variation. This form affects the skin folds, think the armpits, under the breasts, or the groin area. Because these areas are naturally moist, you actually don't see that classic thick, dry scale. And because of that, it's very often misdiagnosed as a standard fungal or yeast infection. Plus, given where it's located, inverse psoriasis carries a disproportionately heavy psychosocial burden. It deeply affects both physical comfort and a person's self-image.
Okay, Part 3, the immune short circuit. All right, so let's get down to the root cause beneath the surface. For the longest time, people just assumed psoriasis was a skin cell problem. But modern immunology has completely redefined our understanding. Psoriasis is actually a highly complex T-cell-mediated inflammatory condition. It's driven by a biological short circuit known as the IL-23 to IL-17 inflammatory axis. The best way to think about it is like a fire alarm that gets stuck in the on position. Your immune cells are essentially miscommunicating, sending these constant, inappropriate signals that keep the skin trapped in a chronic state of severe inflammation.
Let's break down this domino effect into what researchers call a feed-forward inflammatory cascade. First up, you have a triggering event. This could be an infection or even just physical trauma to the skin. That sparks step 2, which activates the innate immune response, where dendritic cells start sounding the alarm. Step 3. These dendritic cells activate specific T cells, notably Th17 cells, by secreting a cytokine called IL-23. Those T cells then completely flood the area with IL-17, which leads us to step 4, skin cell hyperproliferation. The IL-17 literally commands the skin cells, the keratinocytes, to multiply at an unnaturally rapid rate. They pile up, creating those thick, visible plaques we talked about earlier. It's a relentless, self-perpetuating loop. To really grasp just how sensitive this primed immune system is, we have to talk about something called the Kubner phenomenon. This is a fascinating hallmark of active psoriasis. Because the immune system is already hypervigilant and caught in that intense inflammatory loop, brand new skin lesions will often pop up precisely at the sites of a physical skin injury. A patient could go get a tattoo, have a minor surgical incision, or frankly, even just get a mild scratch, and the immune system rushes to the site, mistakenly triggering a brand new psoriatic plaque right over the injury. Section 4. Way beyond the skin. So, zooming back out from the microscopic level, we have to recognize that this inflammation absolutely does not stay confined to the skin. A staggering 30% of individuals with psoriasis will actually go on to develop psoriatic arthritis. And listen, this isn't just your typical joint wear and tear. It's a progressive, inflammatory condition that causes severe joint pain, intense morning stiffness, and, if it's left untreated, irreversible structural damage to the joints. It is the exact same underlying immune short circuit we just talked about, just manifesting in the musculoskeletal system instead. And the systemic ripple effects just keep going. While psoriasis itself isn't directly fatal, the heavy burden of its associated comorbidities absolutely is. We see significant proven links to cardiometabolic diseases, including hypertension and insulin resistance, as well as profound mental health disorders. In fact, this heavy systemic burden unfortunately leads to premature mortality, predominantly from cardiovascular and metabolic complications. Ultimately, the entire body is just stuck in a state of high alert. Which brings us to a really fascinating bi-directional relationship, the link with obesity. It is very much a two-way street. On one hand, adipose, or fat tissue, actively secretes pro-inflammatory mediators that actually amplify systemic inflammation, making the psoriasis much, much worse. But conversely, active weight reduction dramatically improves a patient's responsiveness to therapy. So while obesity can reduce how well modern biologic drugs work, losing weight actively helps the same drugs work exactly as they were designed to. And finally, Part 5, Targeted Treatments and Hope. Even with all this incredible complexity, there is a lot of hope because we now have a highly advanced treatment arsenal. Sure, we still use topicals and targeted phototherapy for milder disease, but the absolute game changers today are the targeted biologic therapies and oral small molecules like TYK2 inhibitors. Because scientists were able to decode that specific IL-23 to IL-17 axis we walk through, we now have medications that act like precision missiles. They selectively interrupt that exact cytokine signaling pathway without indiscriminately wiping out the patient's entire immune system. And just as importantly, this cutting-edge medical intervention is paired with holistic care, really emphasizing smoking cessation, sleep hygiene, and physical activity. The source material for this actually sums it up perfectly, stating, weight loss in individuals with obesity has been associated with reduced psoriasis severity and with a lower risk of psoriatic arthritis development. This is deeply empowering. It tells us that lifestyle management, specifically weight optimization, isn't just generic wellness advice. It is a highly proven, evidence-based therapy that not only clears the skin, but can potentially prevent the onset of irreversible, destructive joint disease. So I want to leave you with this final thought. The iceberg of psoriasis has taught us so incredibly much about the human immune system. If we can now target the exact cellular circuits that cause psoriasis, literally switching off the IL-23 and IL-17 axis with such incredible precision, what other chronic inflammatory diseases can we finally switch off next? The blueprint we are building here could absolutely change the landscape of autoimmune disease forever. Thank you so much for joining me on this explainer, and keep exploring the science beneath the surface.